Good morning, ladies and gentlemen. A big shout out of thanks to Dr. Chaitanya and congratulations to the team Apollo for putting up a fabulous show. Apollo aims at resolving the issues of lung fibrosis, and I'm here to prove my bit. Before I start, ladies and gentlemen, I would like to make a disclaimer. This presentation of mine is purely professional and nothing personal against this gentleman who has been instrumental in teaching me transbronchial lung cryobiopsies and EBIS. When I got a call from Dr. Chaitanya, I was super elated and basking in glory. But then when I saw an email with the agenda, I was a bit confused. Dr. Dhamija, who's going to speak against a tissue biopsy in lung fibrosis? Friends, let me show you the parde ke piche ka story. And then when I was browsing through Times of India, I came across this article which showed cryotherapy, cryobiopsy, lung biopsy, all the words in favor of biopsies, and look who's endorsing it. Dr. Dhamija. I think Dr. Dhamija is under the influence of these two groups. And these groups are, the first is the Fleischner Society, who is a multidisciplinary society interested in thoracic radiology, who came out with a white paper in November 2017, where they described the 4 radiological criteria for the diagnosis of IPF, followed by the ATS ERS guidelines, which came out in September 2018, where they, instead of 3 criteria, they also came out with 4 criteria. I would not go into the depth of all these criteria, ladies and gentlemen, since this is going to be hammered throughout the day, and you probably might be knowing all these things. Way back in 1940, Douglas Bader, he said, guidelines are for the guidance of a wise man, but obedience of fools. So ladies and gentlemen, let me show you one case, and this is a 62-year-old gentleman who had cough with breathlessness for last 3 months, and then he opted to go for a health checkup where his x-ray showed a reticular pattern. On advice of getting an HRCT thorax, he got this, and the diagnosis which came out on the HRCT was most likely probable UIP. Now look at these words, most likely probable. Even the radiologist is not confident, right? He didn't have any exposure history, he had no history suggestive of connective tissue disease. However, it was most likely. He goes to a well-known pulmonologist, and this is the prescription that he gets. So, in a famous novel, Alice in Wonderland, ladies and gentlemen, the big fat cat tells confused and lost Alice that if you don't know which way to go, right, any road would take you there. May I please ask Dr. Dhamija, what would you do in such a case? Will your haunting skills come out to do a transbronchial cryobiopsy, or you have a fantastic thoracic surgery department which is one of its best in the country, and then you have a thoracic surgeon who is always enthusiastic and energetic and ready to help you? So what would you do? And this brings to $1 million question. Why is it very important to give a robust diagnosis in fibrosing ILDs? So if you look at the world of fibrosing ILD, you have IPF, and then you have connective tissue disease related ILD, you have NSIPs, you have chronic HP, and a small subset of IPAF. Up till 2012, there was one single regimen, that is one size fits all in each and every patient. But with the advent of antifibrotics, the scene has changed now. So it's very imperative for all of us to differentiate IPF versus non-IPF. And of course, it is very important for the prognostication of the disease, because when you label your patient as IPF, you know that his median life survival is 2.8 years. This is the radiological and pathological correlation given by the ATS ERS. I'm not worried about the green stuff, when it's definite UIP. But then when you have a definite UIP, you can always have a pathological probable or an indeterminate criteria. Or when you have an indeterminate UIP, look at this black, red and the yellow boxes. So friends, I would like to tell you that what we talk about UIP, NSIP, these are all patterns. So UIP most likely 90% of the times is IPF, but then it can also be occupational, environmental, drug induced, and could be chronic HP or fibrosing sarcoid. So let me show you one case, and this is a 62-year-old female who comes with breathlessness and cough, with having a past history of MI. Her lung function shows a diffusion lung capacity of 70%. The HRCT shows a subpleural pattern, peribronchovascular, no predominance. She has reticular pattern, it has basal predominance, and she also has traction bronchiolactasis with some small mediastinal lymph nodes. When she was subjected to biopsy, it turned out to be fibrosing sarcoid. So way back in 1996, our colleague, some friends from the Royal Brampton said that there is a sarcoid which overlaps with fibrosing IPF. Similarly, not going that far off, we have our friends from PGI who did a prospective study from March 2015 to February 2017, where they studied at 805 cases of ILD, and they showed that 339 cases were sarcoid, followed by IPF, NSIP, CTD, ILD, and HP, and so on and so forth. Coming to my next case, this is a 63-year-old gentleman with cough and breathlessness. He comes with no history of exposure, no history suggestive of connective tissue disease. He is an office person, he doesn't have any occupational exposure, no environmental exposure, and his HRCT shows subpleural reticular pattern with traction bronchiectasis, no peribronchovascular extension, no mosaic attenuation, no ground glass. And when he was subjected to Watt's biopsy, you see a scattered area of fibrosis with intervening parenchyma, right, which is suggestive of an UIP pattern. But then when you look very closely, you have a peribronchial extension with ill-formed granulomas. So he has a chronic HP with an UIP pattern. It's very common, it's common to have chronic HP with an UIP pattern. And when you look at it, when you have heterogeneity on a pathology with peribronchovascular metaplasia with ill-formed granuloma. A prospective case cohort study by Raghu et al. When they studied the patients having diagnosed as IPF under 2011 criteria, later on turned out to be chronic HP. And then our famous Indian ILD registry, which showed that the most common ILD in our country is HP, followed by connective tissue disease ILD, and then IPF. So ladies and gentlemen, if I give you a glass of water or a cold drink, this is a glass of a liquid, how would you say that this is a water or a cold drink? Difficult, right? So अपनी अकल लगाओ, दिखावे पे मत जाओ, right? This can be a Sprite. So similarly, there has been a discordance in the radiology pathology where this paper from the IPF research net says that all those patients who had inconsistent of UIP of 2011 criteria. When they underwent a biopsy, they had a pathological UIP. So Dr. Karan Madan from AIMS has very eloquently said, look before you leap. Look before you leap. When he has said that in our scenario, it is very imperative to include a pathologist and have a tissue diagnosis and do a multidisciplinary discourse. Ladies and gentlemen, I would like to confess in front of you and the chairpersons over here that everything in fibrosing ILD is not a debate. It can also be a duet. So friends, मैं गीता पे हाथ रख के कसम खाती हूँ कि जो भी कहूँगी सच के सिवा कुछ भी नहीं कहूँगी. There are certain instances where you don't need a biopsy, and so which are those conditions? When you have a good history with a good HRCT, then a person or a patient who has got definite UIP pattern, a patient who has a CTD ILD, patient who has chronic HP with significant history of an exposure doesn't need a biopsy. Having said that, 90% of the definite UIP pattern on an HRCT turns out to be IPF. However, the caveat is that we get the definite UIP pattern in 50 to 60% of the cases only. And if our patient has a probable UIP, and when you rule out by the history, the occupational exposure, the drug history, the environmental exposure, and if the patient's age is more than 60, then he is most likely to have IPF. There's a consensus statement by our colleagues on the diagnosis of IPF, and they have very nicely recommended that doing a surgical lung biopsy where the HRCT pattern is not definite UIP. They further go on and recommend that a transbronchial lung biopsy is comparable and can be used as an alternative to surgical lung biopsy, but in a specialized institution. So friends, when do we do a surgical lung biopsy? So it is done in a patient who has a probable UIP on an HRCT, chronic HP, various other IIPs, cystic lung disease, and all those who have a failed diagnosis on a transbronchial lung biopsy or a transbronchial cryobiopsy. When do we do a cryobiopsy? Cryobiopsy is a procedure of getting a transbronchial biopsy using a cryo probe, which uses a Joule-Thomson effect. And if you compare the size of a tissue which you get through a transbronchial cryobiopsy, which is much bigger than a transbronchial lung biopsy, and there is a study by Dr. Sejal Duria et al. From PGI Chandigarh which says that when a transbronchial cryobiopsy was used after a multidisciplinary discussion, the yield was in the range of 78.1%. So what is the role of a multidisciplinary discourse? So Kevin Flaherty and Talmadge King et al., when they studied the frequency of diagnosis of IPF, they said that when you combine a clinician, a radiologist and a pathologist, the yield and the frequency of diagnosing IPF is much better. Following which, in the Blue Journal, et al. Says that there is no gold standard for the diagnosis of fibrosing ILDs. However, they are all silver standards, but histopathology can be identified silver standard of all. So together it's a teamwork which wins to give a correct diagnosis and prognosis to our patient. Friends, I would like to say that if you take this guys and produce a movie, is a definite 100 crores. But then if you look at these parties, right? And I mean, you cannot be definite that who is going to win at this center. It is all about It's all about the local factors, the person who's contesting from that place, and so on and so forth. So probable any party can win at the center. But when you see a thing like a Pulwama, and what is going on in the mind of this guy, right? And how is he going to tackle with this? He has to do a surgical strike. So ladies and gentlemen, we as pulmonologists have to do a surgical strike or give a tissue to give a perfect diagnosis in a probable, indeterminate or an inconsistent cases. In summary, I would like to say that history taking is very pivotal. A good history of smoking, occupation, drugs, environment. You can clinch diagnosis most of the times. A good HRCT with this technique is very important, and you need to talk with your radiologist, give a good history to your radiologist, and you can always tell your radiologist what you are thinking, and then when you should do a biopsy in a case where there is a definite UIP, when there is CTD-ILD, chronic HP with a history of an exposure, and you do a biopsy, in a case where you have a probable UIP and you have a chronic HP, other IIPs where you have to differentiate NSIP from UIP, and also in cystic lung diseases. So I would like to end by telling you that choose the patient, but choose wisely for a good and a better diagnosis. Thank you very much.